Hi, everyone. Welcome back. This week, we're going to be moving on to chapter 19, where we take a look at the respiratory system. We'll be spending the next 2 weeks looking at this system before we move into our midterm review before the midterm exam. This week's focus is primarily going to be looking at the overall organization of the respiratory system. We're going to spend a lot of our time looking at the structure and how that structure leads to the specific function. One of the first things we need to do is to define the difference between ventilation and respiration. Now, ventilation is essentially just the movement of air into and out of the lungs. So I want you to think of a patient who is on a ventilator. Okay, what is that ventilator doing for them? It's simply pumping that air into them. It's not forcing anything into their bloodstream ultimately. It's just simply supplying their lungs with the air that they would normally be taking in on their own. So when we breathe in through inspiration, inhalation, we're taking that air from the external environment into our lungs. And when we expire through exhalation, that's when we are breathing out that air. Okay, so with ventilation, think bulk flow. Now, comparing ventilation then to respiration, two very different physiological activities here. With ventilation, we're simply increasing the volume of our thoracic cavity so that we draw air into our lungs during inspiration. And then with expiration, we're decreasing the volume to force air out. When we look at respiration, we're focusing on the gases that are going to be diffusing from the external environment into our bloodstream and vice versa, from our bloodstream out to the external environment. Now, there are two main types of respiration that we're going to be looking at: external respiration and internal respiration. Internal respiration is also known as cellular respiration. We focused on this in biology last semester, where we looked at how our cells take up the oxygen that was delivered to them by our systemic arteries, and how the cells then utilize that oxygen to make ATP, to make the usable energy so that the cells can function. The process by which oxygen moves from our blood into the cells is known as internal respiration. Now, external respiration occurs between the most terminal portions of our bronchial tubes, known as the alveoli. And we've talked about alveoli specifically because they are made up of simple squamous epithelial tissue, and so they are very thin to allow for gases to be able to diffuse across those cells. So external respiration looks at the air that we've drawn in to those alveoli. Ultimately, the oxygen in that air is going to be capable of diffusing into the capillaries that surround these structures. And so the movement of oxygen from within our lungs into our bloodstream, that is external respiration. And internal respiration is the process by which oxygen is capable of moving into our body's cells. Here's a diagram to help give a bit of a visual there. With external respiration, we're simply drawing air in, remember, through ventilation. That oxygen will get to those terminal portions of our bronchial tree. Once in the alveoli, oxygen can then diffuse from the alveoli into the surrounding capillaries. That is external respiration. With internal respiration, that oxygen that got into our capillaries is then going to be sent back to the heart through the pulmonary veins, into the left atrium, left ventricle, out through the aorta, and then transferred somewhere throughout the body. Once in the blood capillaries within our tissues, that oxygen is able to then move into the cells, where the cells can use the oxygen to be able to make ATP through aerobic respiration. All right, so external respiration is the exchange of gases between the alveoli and the capillaries surrounding them, and internal respiration is between the blood capillaries and the tissue cells. So one of the obvious functions that we are going to spend more time next week talking about is the ability for our respiratory system to take oxygen in from the external environment into our blood, and then ultimately remove carbon dioxide from our blood so that we can ultimately breathe it out. Secondly, because carbon dioxide is so closely connected with overall proton levels within our blood and therefore acidity, we're able to regulate our overall blood pH by either increasing or decreasing the amount of carbon dioxide that we remove from our blood. Also, the paranasal sinuses that connect to the nasal cavity, they're responsible for warming and moistening that inhaled air. As well, we have the ciliated cells that line our upper respiratory tract that are responsible for filtering particles from the air that we inhale. We also have the olfactory nerve endings that are located within that nasal epithelium, And those nerve endings are what give us the ability to be able to smell. And then lastly, here within the larynx, we have what's known as the glottis, and that's where our vocal cords are located. So when we speak, it's the air that's moving past these vocal cords with specific tensions on them, which then vibrate at specific frequencies and give us our voice. So in order for us to discuss the respiratory system, we need to review the body cavity in which the main respiratory organs are located. That would be the thoracic cavity. If you recall, the thoracic cavity is one of our ventral body cavities, right? Located in the anterior portion. The thoracic cavity is divided into three main sections. The two lateral cavities are known as the pleural cavities, and the pleural cavities house our lungs. Now, the mediastinum is also important to the respiratory system because this is where our trachea ultimately enters into the thoracic cavity and then splits into two primary bronchi. And it's the primary bronchi that are the tubes that ultimately feed in to each of our lungs. Now, if you recall, all of these body cavities, they are all lined by specific types of serous membranes. We just looked at the pericardium, which is the double-layered serous membrane that surrounds the heart. Well, the double-layered membrane that surrounds the lungs is known as the pleura. And the pleura, like all serous membranes, is a double-layered serous membrane with two layers and a space between. And in that space between these two layers, we have a specific type of serous fluid, which is known as pleural fluid. Now, the two layers, recall, the innermost layer is known as the visceral pleura, and that is the layer that contacts the lungs directly. And then we have the outer layer, which connects to the inner part of the rib cage, and that is known as the parietal layer of the pleura. Now, the pleural fluid within this intrapleural space is responsible for helping to decrease friction by increasing lubrication. And so as we breathe in and we breathe out, these two layers, the parietal and the visceral, should be able to move against each other very smoothly without a lot of friction. In this image here, we are looking at a cross section. You can see that we are looking in the thoracic cavity, obviously, because we have the presence of ribs. As well, anteriorly, you can see part of the sternum. Here we are looking at the heart, and you can see that here you can see the heart located within the mediastinum, specifically within the pericardial cavity. And then you can see the presence of two lungs within the pleural cavities. Now, if you recall, the heart sits towards the left of the midline. So if you were trying to figure out, are we looking from the top down or from inferior to superior perspective, the heart sits towards the left of the midline. Also, you're going to see that the left lung is also much smaller than the right. And so we know that this would be the individual's left side. Okay, so in this case here, we're looking at a cross section from an inferior to a superior perspective. Over here, you can see labeled the parietal pleura, which would be contacting the thoracic cage itself. And then you see the visceral layer would be the layer contacting the lungs specifically. And so the intrapleural space would be this dark space located between the visceral and the parietal pleura. Now, we're going to take a look at the organization of the respiratory system from both a structural perspective, dividing into upper and lower portions. And then we're going to take a look at the functional divisions of the respiratory system, i.e., where is air simply just passing through, and then where is respiration actually taking place. So we're going to start here looking at the structural divisions of the respiratory system. We have an upper portion to the respiratory system and a lower portion to the respiratory system. The dividing portion here occurs at the larynx. Anatomically, this portion right here where you have the opening of your glottis, which is the opening into your trachea, that typically defines the boundary between upper and lower. But for our purposes, we are going to use the larynx as that defining boundary between the upper and the lower respiratory system. All right, so if you were to take a breath in, if it's cold outside, remember we talked about this, you should probably not breathe directly in through your mouth. Why? Because there is going to be less ability for your body to be able to warm that air up. So it's best and less painful for you to be able to then slowly breathe in through your nose, taking that air in. And as those nasal concha are able to circulate that air, the air is going to be warmed and moistened as it passes through the nasal cavity. So it's important to remember, though, both the oral cavity as well as the nasal cavity are both conduits through which we can enter into the respiratory system. So we're going to follow through here through the nose into the nasal cavity, finally back to the posterior aspect of the nasal cavity where we enter into the nasopharynx. The pharynx has three portions: nasopharynx, oropharynx, and laryngopharynx. Air is then going to move anteriorly into our larynx, and then through the larynx, we now have passed through the entire upper respiratory system. From the larynx, we then pass directly into the trachea, which you'll notice here is supported by a number of cartilaginous rings. We get to take a look at those in a little bit more detail, but most of this is supported by cartilage. Why? Well, we want to be able to hold this whole windpipe open. If it weren't supported by cartilage, any of these larger tubes would be more prone to collapsing anytime we breathed out. And then we'd be starting all over again, trying to completely inflate the tube. So these cartilaginous structures, they keep the overall bronchial tubes open. Now, from the trachea bifurcates here into left and right primary bronchi. And the primary bronchi are the structures that are ultimately going to be feeding each of our lungs. Okay, so you have two primary bronchi, a left and a right. Then we have further divisions of those primary bronchi into secondary and tertiary bronchi. Those ultimately terminate into bronchioles, and the bronchioles are the first structures that do not have any cartilaginous support to them. Instead, they have smooth muscle that surrounds them, and that allows them to be able to bronchodilate and bronchoconstrict. And then lastly, we end up in the alveoli, and those are those terminal portions I was speaking of before. They're like grape-like clusters at the ends of all of your respiratory bronchioles, and that is the site where gas exchange will take place. So remember, the larynx, that is the terminal portion of the upper respiratory system. Past the larynx, we move into the lower respiratory system. So we move from the trachea into the primary bronchi, secondary, tertiary, into the bronchioles, and finally the alveoli. Now, from a functional perspective, we also need to divide the respiratory system into two main components. We have the conducting zone, which is where ventilation is going to be taking place. Okay, remember, ventilation is looking just at bulk flow of air. And so ultimately here, the conducting zone runs all the way from the nose or your mouth, all the way through the nasal and oral cavities till we get to the pharynx, larynx, trachea, primary, secondary, even tertiary bronchi, bronchioles, and the final portion of the conducting zone are the terminal bronchioles. And this is very important for you to highlight. The terminal bronchioles mark that final portion of the conducting zone before we move in to the respiratory zone. And you'll notice if you follow through, the terminal bronchioles, which mark the end of the conducting zone, they're located here before the respiratory bronchioles. Okay, so it's important to remember why they are terminal, because they mark the end of the conducting zone. Past the terminal bronchioles branch into respiratory bronchioles. The respiratory bronchioles, alveolar ducts, and alveoli are all sites where respiration is able to take place. And so the conducting zone all the way through the larynx into the trachea, primary bronchi, secondary bronchi, tertiary bronchi, bronchioles, terminal bronchioles, marks the end of the conducting zone. And in the respiratory zone, we have the respiratory bronchioles, alveolar ducts feeding into the alveoli. So now we're going to spend some time looking at all of these various parts of the respiratory system in more detail. We're going to start off here looking at the nasal cavity to begin with. Now, a main function of the nasal cavity is to be able to draw air in and circulate that air in order to warm and moisten it within that environment. You'll remember that we have a mucous membrane that lines the intranasal mucosa, and that lines all of these nasal conchae. And it's the nasal concha that are ultimately going to be creating turbulence within the nasal cavity, which is going to help to further warm the air as it passes through. The olfactory nerve also sends fibers directly innervating that nasal mucosa. where we are capable of sensing smells within our environment. And then lastly, the nasal cavity also provides us with a resonance chamber. Specifically, the sinuses themselves. If you have a sinus infection, you notice that your voice sounds significantly different. If I just simply plug up my nose right now, my voice becomes very congested and plugged up. Okay, so we rely on our nasal cavity and the paranasal sinuses to be able to give us that resonance of our voice. Now, bounding the nasal cavity, we have the external nares, which are our nostrils. Internally, we have our internal nares. Now, remember, the nasal cavity itself is divided by the nasal septum, which is made up of the perpendicular plate of the ethmoid bone and the vomer. This can give you a perspective here from the external nares through the nasal cavity to the internal nares. And the internal nares marks that boundary from the nasal cavity to the nasopharynx. And it's within the nasopharynx here, as we move further into the respiratory tract, that you'll see that the eustachian tubes open into the nasopharynx. And the eustachian tubes are connected directly to our middle ear, and they're responsible for helping to equilibrate pressure within our middle ear. In infants, eustachian tubes tend to be more horizontal anatomically, and also there can be variance from individual to individual, where some infants would have more horizontal eustachian tubes. As you can see, as we get older, because our anatomy further develops, the eustachian tubes are then more angled as we age, which enables us to be able to drain fluid a lot easier from that middle ear. This is where middle ear infections can be very prevalent amongst young infants, because just due to the morphological structure of the eustachian tube being more horizontal, infants can be more prone to poorer drainage, and as a result, be more prone to middle ear infections. Now, as mentioned before, we have the nasal conchae, the superior, middle, and inferior. Remember, the superior and the middle are part of the ethmoid bone, whereas the inferior nasal concha is its own facial bone. Now, all of these are then lined by the olfactory mucosa. What is the mucosa? Mucosa is that lining, that mucus epithelium that lines our upper respiratory tract. And so when those conchae are lined by the epithelial tissue, they are then each known as a superior, middle, and inferior meatus. Now, the olfactory mucosa plays a huge role in being able to provide us with protection from external pathogens, as well as other foreign particulate. Ciliated refers to the fact that there are those little tiny hairs on the surface. And what do we know about ciliated epithelium? They all contain goblet cells. And so the olfactory mucosa is set up so that it is lined by all of these ciliated epithelial cells that produce mucus. So producing over half a cup of mucus per day, we are capable of ultimately purifying the air that's going to enter into our lower respiratory tract by trapping a lot of those irritants and foreign pathogens within the mucus lining of our olfactory mucosa. And then ultimately the cilia are going to beat in that one direction, which are going to help to then propel that mucus up and out of our bodies. If you recall, the four bones that contain the paranasal sinuses are the craniofacial bones, the frontal bone, the maxillary bone, the ethmoid, which you can see here located more anteriorly, and the sphenoid sinus. Now, the paranasal sinuses, they act to decrease the overall weight of the skull bones, but also lined with mucus epithelium, they're capable of further trapping foreign particles and be able to prevent them from entering into the deeper portions of our respiratory system. Ultimately, any of the mucus that's produced in these sinuses will all drain back into our nasal cavity. Now, from the external nares through the nasal cavity, internal nares, we then enter into the pharynx. And the pharynx you can think of as your throat. All right, so whether air is coming in through the nasal cavity or oral cavity, it'll ultimately enter into the pharynx at some point. Now, the pharynx is located superior to the larynx, but also anterior to the cervical vertebrae of the neck. Now, the three main divisions of the pharynx are most superiorly the nasopharynx, the oropharynx, and then most inferior, the laryngopharynx. Now, if you take a look at these prefixes, They all describe to you specifically which cavity that part of the pharynx is connected to. So let's look here. The nasopharynx is connected directly to the nasal cavity. The oropharynx is connected to the oral cavity, and the laryngopharynx is connected directly to the larynx. Okay, so always look back to your prefixes, suffixes, root words, because they will usually help you in identifying the structures, maybe associations or even locations. Now, when we look at the digestive system, we're going to see how when we swallow, this soft palate lifts up and blocks the nasal pharynx. So ultimately, food that's brought in through the mouth will be pushed back to the oral pharynx and move inferiorly. That's great because we really don't want to be spraying out any kind of fluids from our noses. But ultimately, the pharynx acts as a passageway for food through the oropharynx, laryngopharynx, liquid as well, oro and laryngopharynx, or air, which can then pass through the naso, oro-laryngo, or from the oral cavity directly to the oro and laryngopharynx. Now, some structures also located within the pharynx, specifically within the naso and oropharynx, are our tonsils. Within the nasopharynx, we have what are known as our adenoids, and those adenoids are specifically called pharyngeal tonsils. Now, you'll notice here in this diagram that we've had a bit of a portion of our soft palate removed from this diagram, because typically you would like to see the uvula that would be hanging down here from the soft palate. Now, we'll get into talking more about the uvula in the digestive system and its function. But the reason why it's been cut away here is to be able to show you the pharyngeal tonsils that are located superior to the soft palate within that nasopharynx. And so if we look at this image here, you can see there's your soft palate, and there is your nasopharynx. There are the pharyngeal tonsils located superior to the soft palate within that nasopharynx. Now, when you open your mouth and you say ah, and you're looking to the back of your throat, those large masses of lymphoid tissue that you see are the tonsils. Those are the ones that you would think of as the tonsils whenever you talk about them. These are specifically known as the palatine tonsils. Why? Because they are closely associated with the soft palate. And then at the base of your tongue, much harder to see, there are the lingual tonsils. So ultimately, between the nasopharynx and the oropharynx, we have three sets of tonsils. And the tonsils, as we talked about in the lymphatic system last week, tonsils are responsible for providing us with immune support, right? They are lymphoid tissue, specifically lymphatic nodules. And we see them here to provide us with immune support because our oral cavity and nasal cavity are exposed to the external environment. Now, some of you may have had your palatine tonsils or your pharyngeal tonsils. You may have had your adenoids removed. And you might be wondering, okay, so what kind of immune support do I have there? Well, limited, but you still do have lymphatic nodules there at the base of your tongue, lingual tonsils. And typically, palatine tonsils as well as the pharyngeal tonsils are removed because either through chronic recurrent infections and or the fact that they swell to a point at which they start to block the airway. Typically, your doctor is wanting to see that there is some sort of compromise that could actually prove to be more of a life-threatening issue. And so here you can see again the adenoids, the pharyngeal tonsils located in the nasopharynx, and then here associated with the soft palate, the palatine tonsils, and at the base of your tongue, you have the lingual tonsils. Now moving inferiorly from the oral pharynx, we're moving into the laryngopharynx. And the laryngopharynx is located at the same level as the hyoid bone. Remember, this is that floating bone that is part of the axial skeleton that we took a brief look at back when we looked at skeletal anatomy and then really haven't talked about it since. It's located at the same level as the hyoid. And you can see here that the laryngopharynx actually connects directly to the esophagus and then anteriorly connects to the larynx. And so when we swallow food, the food bolus is pushed back by our tongue and ultimately is going to be more likely to want to move posteriorly down the esophagus. And when we breathe in, we're actually drawing that air in, and so it's more likely to be able to move anteriorly. Now, the larynx runs from your C4 to your C6 cervical vertebrae, and the larynx is an incomplete cartilaginous structure. It's made of a number of paired and unpaired pieces of cartilage that are all held together by various ligaments. And those cartilaginous structures are the thyroid cartilage, cricoid cartilage, epiglottis, the arytenoid, as well as the corniculate cartilage. Now, if you all go to the anterior portion of your neck, you should hopefully be able to feel the Adam's apple, that prominence, typically larger in males, but females should be able to palpate theirs as well. That structure is known as the laryngeal prominence. The laryngeal prominence is located on the thyroid cartilage. Now, the thyroid cartilage is the largest of the cartilaginous structures that make up the larynx. It is unpaired, so there's only one, and it is open posteriorly. The reason that it's named the thyroid cartilage is because our thyroid gland sits directly in front of it. Now, a lot of these cartilaginous structures are all made up of hyaline cartilage, which you will remember is somewhat flexible, but is really good at holding its shape. And it's the thyroid that connects superiorly to the hyoid bone. Now, moving inferiorly from the thyroid cartilage, we have the cricoid cartilage. So if you just run your fingers down a little bit, or even if you place your fingers on your laryngeal prominence, and if you swallow, move your fingers down a little bit, you should feel a bit of a ridge that will move up and down as you swallow. Well, that ridge further down, that is your cricoid cartilage. And the cricoid cartilage is another unpaired, so there's only one of them, and it is a ring-like structure that expands posteriorly. Now, we've been looking in anatomical position. If we were to turn around and look from a posterior view, you would see here that the thyroid cartilage is open posteriorly, and the cricoid cartilage expands posteriorly to form a complete ring. And the last of the unpaired cartilaginous structures is the epiglottis. And in any of these lateral views, when we viewed the epiglottis, you saw it as this flap right here. This is the epiglottis itself, and this is its ligamentous attachment directly to the hyoid. Now, the epiglottis is responsible for closing off our airway whenever we swallow. So as I mentioned, as food or liquid passes through the oral cavity into the oral pharynx, laryngopharynx, the epiglottis is going to close and it is going to shut off the glottis and our windpipe. So ultimately food is forced posteriorly. Now, this is where if you're talking and eating all at the same time, that's confusing things for the epiglottis. And so this is where you can be more prone to then choking because the epiglottis may be up because you're talking and trying to get air out, but then also at the same time, food is moving downward and so is more likely to then bypass the epiglottis and cause you to choke. Now, moving on, the two final paired cartilaginous structures that we have are the arytenoid cartilage as well as the corniculate cartilage that sits on top of the arytenoid cartilages. Now, the arytenoids are paired and they are located superior to the cricoid. They're important because they attach the true vocal cords and pharyngeal musculature. And so when we alter the way in which we speak, it's contraction of specific muscles that causes those arytenoids to either tighten the vocal cords or loosen them to allow us to be able to produce the sound of our voice. And finally, here you can see the corniculates that sit directly on top of the arytenoids. And the arytenoids attach directly to the vocal ligament. And the vocal ligament then is surrounded by tissue. And the tissue is what's going to be vibrating at a specific frequency as the air passes through our opening, which is known as the glottis. And so let's take a look here at the glottis, specifically at the corniculate and arytenoid cartilaginous structures and how they attach to those vocal ligaments and can tighten or loosen our vocal cords, allowing us to change the pitch and sound of our voice. So here we are looking from a superior to an inferior view. Okay, so we're looking top down. You can see here we have the thyroid cartilage. Remember, the thyroid anterior prominence is known as the laryngeal prominence, and we know it is open in the back. So this must be the posterior surface and this must be the anterior surface. This ring-like structure, that is the cricoid cartilage. You can see how it's thicker posteriorly than it is anteriorly. Now, the arytenoid cartilaginous structures, these are the arytenoids. And then sitting on top of the arytenoids, we have the corniculate cartilage. Okay, so the arytenoids and the corniculates, they are paired, okay, which means there's two of each. Now, as mentioned before, the arytenoids, they have little muscles that attach to them. And at the other end, they have the vocal ligament attached to them. And ultimately there, this is what forms the opening, which is our glottis. And so here you can see the glottis is almost closed. And here you can see the glottis is open. And so it's the alternation of the contraction of different muscles that coordinate the movement of those arytenoid cartilages and then cause them to pull on the vocal ligaments. And so ultimately, if the vocal ligaments are tighter, the frequency of the sound waves is going to be much higher. And if the vocal ligaments are a lot looser, then you're going to end up with larger wavelengths, so lower frequencies. I would highly recommend at this point that you take a look at the video that takes an endoscopic approach to looking at a number of operatic singers as they sing to see how their glottis changes shape to be able to produce the various pitches that you hear them singing. So remember, now we are moving from the upper respiratory tract from a structural perspective into the lower respiratory tract. And the trachea conducts air from the larynx superiorly all the way through the mediastinum. Remember that central cavity located in the thoracic cavity. And the trachea ends here at this bifurcation known as the carina. And the carina divides then into primary bronchi. Remember, the primary bronchi are the tubes that ultimately supply the lungs with air. Okay, so we have one of each, one on the left, one on the right. Now the trachea runs from about C6, the inferior portion of the larynx, all the way down to T5, which is the level of the carina. It's located anterior to the esophagus, and it's composed of these cartilaginous structures that keep it open. Now, something you may have not been able to appreciate when looking from an anterior perspective is that these cartilaginous structures are C-shaped. And because they are C-shaped, they are open posteriorly. Now, there is a muscle that runs posteriorly and connects these to one another, which is known as the trachealis muscle. Now, besides preventing the trachea from collapsing and keeping it open when we're breathing out, it also allows for the esophagus to be able to expand anteriorly. I'm sure we've all been in that boat where you've just been eating really fast, you're not chewing your food, you're loving what you're eating, and all of a sudden you can feel your food move all the way down your esophagus. And it feels like it's never going to pass through until finally it empties into your stomach. Because the trachea is supported by these C-shaped cartilages, the esophagus is capable of being able to expand into the trachea ever so slightly. So when you're feeling that kind of discomfort, it's likely that you're stretching the esophagus to a point where it's starting to put pressure now on the other structures in the area. Now, the inner layer of the trachea is lined by the respiratory mucosa, and the respiratory mucosa is similar to the olfactory mucosa, where we have pseudostratified epithelial tissue containing both goblet cells as well as cilia. And so they are going to be doing the same job as our olfactory mucosa was doing. We are producing mucus so that we're trying to trap foreign particulates as well as foreign pathogens. And then the cilia are going to be beating in this upward direction to try to keep the mucus up and out of our lungs, ultimately removing it from the body. Now, the middle layer, as we've mentioned, is made up of 16 to 20 C-shaped cartilaginous rings and the trachealis muscle that runs posteriorly. And then finally, all of this is held together by the external layer that's made out of fibrous connective tissue. Now, it's important to note that the respiratory mucosa as well as olfactory mucosa, lined by that pseudostratified ciliated epithelial tissue, the cilia can be destroyed by smoking. And so ultimately, that's where smokers can develop a smoker's cough because the cilia are no longer able to do the job of keeping mucus up and out of the lungs. And so they rely on the coughing reflex to do so. Now, the positive here is that the cilia are capable of being able to regenerate themselves as well. Now, from an external perspective, we've already covered the carina, which occurs here at the level of T5. From an anatomical landmark here, we can see it at the sternal angle. And then where the primary bronchi left and right enter into the lung, this region of the lung is known as the hilum. In addition to the primary bronchial structures that enter into an individual hilus at this point, you're also going to have those pulmonary arteries and veins entering the lungs and exiting from the lungs. You'll also notice here that the left lung is slightly smaller, as we mentioned previously, and this is partially due to the fact that we have the heart sitting within the mediastinum slightly towards the left of the midline. And because this all exists within this enclosed thoracic cavity that is contained by our rib cage, there are limitations with space. And so ultimately the left lung has this cardiac notch, which provides extra space in order for the heart to be able to fit and sit towards the left of the midline. And to review, remember we have the lungs sitting within the pleural cavities, and the pleural cavities are lined by the pleural membranes. And the pleural membranes are serous membranes that contain a parietal pleura that lines the inner portion of the rib cage, and a visceral pleura that contacts the lungs directly. And between the visceral and the parietal pleura, we have the pleural cavity, which contains the pleural fluid. We're now going to move into focusing on all of the bronchial structures here that feed the lung. And then we're going to take a look at the anatomy of each of our lungs, both left and right. So from larynx, we've moved into the lower respiratory tract, through the trachea, down to the carina at the level of T5, where we have a split into primary bronchi. The left primary bronchi supplies the left lung, entering here at the hilus. And the right primary bronchi enters the hilus of the right lung to supply it with oxygenated air. Now, when the primary bronchi enter the lung, they then divide into secondary bronchi. And there is one secondary bronchi that is dedicated to each lobe of the lung. And you'll see here, looking at the right lung, we have a horizontal fissure and an oblique fissure. And that horizontal and oblique fissure divide the right lung into three separate lobes. When looking at the left lung, you can see here that we only have the left oblique fissure, which then divides the left lung into only two lobes. And so the left lung has two lobes, it's smaller. The right lung has three lobes. Therefore, the left lung has two secondary bronchi supplying each of those lobes, and the right lung has three secondary bronchi supplying each of those lobes. Secondary bronchi then split into tertiary bronchi, and you'll notice that the bronchial system is set up like an inverted tree, where the trachea is similar to the trunk of a tree, and then you have your primary bronchi, or the larger branches, and then you get smaller branches, the secondary bronchi. Those secondary bronchi then split into tertiary bronchi, and then we're going to look further and further as we get into the bronchioles and finally the alveoli. So from the primary, secondary, tertiary bronchi ultimately branch into bronchioles. And the bronchioles split into smaller terminal bronchioles. And remember, it's the terminal bronchioles that mark the end of the conducting zone. Now, in the bronchioles, there's also the replacement of smooth muscle. Remember before, we had cartilaginous ring structures that were supporting the trachea, the primary bronchi, secondary bronchi, even tertiary bronchi. Once we get into the bronchioles then replace that cartilage with smooth muscle. And the smooth muscle allows for them to be able to dilate and constrict. So remember when we looked at the blood vessels, we referred to that as vasodilation and vasoconstriction. Well, now we're in bronchial structures, so we're referring to this as bronchodilation and bronchoconstriction. Okay, similar phenomenon happening. When the smooth muscle contracts around the bronchioles, they will bronchoconstrict, and when the smooth muscle relaxes, they will bronchodilate. Now, at the terminal bronchioles, we then are at the end of the conducting zones. The terminal bronchioles are then going to branch into the respiratory bronchioles. Now, here's a different perspective looking at the different lobes of the lungs. You'll recall on the right-hand side, we had three separate lobes, and on the left, we had two separate lobes. We have an oblique fissure on both. It's the presence of the horizontal fissure on the right that gives us that additional third lobe. So you'll see here that we have superior lobes for both left and right. We have inferior lobes for both left and right. The additional lobe in the right lung is known as the middle lobe. Now on the next slide, you're going to see further lung lobe divisions, because what we're going to do now is break these lobes down into smaller and smaller pieces until we ultimately have your smallest functional unit, which is known as a lobule. And each lobule contains a lymphatic vessel, an arteriole, and a venule, so obviously a capillary bed, and then a branch from a terminal bronchiole. So the way that we find these smaller subdivisions is by first off finding a lobe, okay? So let's take a look at the right lung, and let's choose the superior lobe. If we take the superior lobe, which is supplied by a secondary bronchus, and we divide it, let's just do this and divide it into 4, okay? So we divide it into 4 pieces. Each of these 4 pieces, those smaller segments, they would all be supplied by a tertiary bronchus. The secondary is going to connect to the lobe, and then ultimately the secondary bronchus is going to split into smaller tertiary bronchi, and each of those, let's just say 4 for simplicity's sake, each of those 4 are going to supply one of those smaller components of the lobe. Now, if we take one of those quadrants that we divided the lobe into, and we divide it into smaller little pieces, each of those compartments is going to be supplied by its own lymphatic vessel, arteriole, venule, and its own terminal bronchiole. And those smallest segments are known as lobules. Okay, so you can define the lobule as that smallest sort of functional unit of your lung. Okay, so from a functional perspective, we have the conducting zone and the respiratory zone. So we've looked through the trachea, bronchi, so primary, secondary, tertiary bronchi, and it's the tertiary that are going to supply those smaller segments of the lobes. And then finally, we have further divisions into bronchioles and terminal bronchioles. And it's the terminal bronchioles that are ultimately going to be supplying the lobules, those smallest functional compartments that we've divided the lobe into. And along with the terminal bronchiole, the lobule is also going to be supplied by the lymphatic vessel, arteriole, venule. Now, all of those structures then are going to feed into this respiratory zone. Because remember, it's at the level of the respiratory zone where you're going to want to have the capillaries surrounding these structures. Why? Because these are the structures through which gas exchange can occur. Respiratory bronchioles, alveolar ducts, and finally the alveoli, they are all capable of gas exchange. Now, because the alveoli are so thin, the overall surface area of them is very large. And that allows us to be able to really rapidly exchange a lot of oxygen and carbon dioxide through diffusion. If you were to take all of that simple squamous epithelial tissue that makes up your alveoli, and you were to spread that out, it would roughly cover the size of a tennis court. So again, we're looking at another example of how the smallest, thinnest structures have such huge surface areas to allow for a lot of transport across those surfaces to take place. So we're going to zoom in here on this terminal portion of the respiratory zone at the alveoli and take a look at the 2 different types of cells that make them up. And so here you can see the alveoli are made up of a number of layers of simple squamous epithelial cells. The cells that actually make up the alveolar walls, those are known as type 1 alveolar cells. And so here you can see this would be one type 1 alveolar cell. This would be another, and this another. Okay, here zooming out, that would be another, that would be another, that would be another, that would be another. Okay, so all of the simple squamous epithelial cells that make up the actual structure of the alveoli, those are known as type 1 alveolar cells. Now remember, if the alveoli are made up of simple squamous epithelium and they're surrounded by capillaries, remember the capillaries are made up of a single layer of simple squamous epithelium, known as endothelium. And so we have about 0.2 microns between the capillary and the alveoli that oxygen and carbon dioxide have to diffuse across in order for oxygen to diffuse from our alveoli into our bloodstream and for carbon dioxide to be able to diffuse from our bloodstream out into our alveoli. Now, what allows us to be able to keep these alveoli open even when we are breathing out are the type 2 alveolar cells. So here you can see an example of one of those type 2 alveolar cells. The reason that these are so crucial is because they secrete a substance that's known as surfactant. And surfactant is a substance that helps to decrease the surface tension of all of the opposing layers of this one alveoli. You have to remember, if this is all very, very, very thin, simple squamous epithelial tissue, when you breathe out and they start to deflate, what's keeping them from just totally sticking together? Well, it's the surfactant that's secreted by the type 2 alveolar cells that lines all of these inner portions of the alveoli that helps to keep them open and inflated when we inhale and finally when we exhale. I want you to think of the example again of going to the grocery store and trying to separate those produce bags. You know how difficult that is, especially in the winter when your hands are dry, everything's dry, and everything clings together? The same idea goes for the alveoli. Okay, if we did not have this surfactant being produced by the type 2 alveolar cells, they would be likely to simply collapse. And it would be difficult for us to inflate the alveoli and harder for us to get air down into those regions. Next week, we're going to get to take a look at infant respiratory distress syndrome, where when you have a premature infant that is not yet producing surfactant, they require oxygen to be delivered to them because they're unable to simply breathe on their own. Okay, and that brings us to the end of part 1 of the respiratory system. So next week, we're going to be taking a further look now at more of the functional perspective of the respiratory system. We're going to take more of a specific look at how oxygen is capable of being able to diffuse into our bloodstream, and then once it's in our bloodstream, how it's transported by hemoglobin as well as being dissolved in our plasma to all of the tissue cells in our body. And then we're also going to take a look at then how carbon dioxide is picked up from our tissue cells, delivered back to the lungs, so we can then breathe it out. So if you have any questions in the meantime, please feel free to reach out. Otherwise, I look forward to seeing you all in tutorial next week. Take care.